right, for this portion of our video, we're going to be talking about some of our clinical preferences and based on all the research and everything that we've talked about in the previous modules. So the first thing I want to remind you of is you always want the op report. If for some reason you are sent a patient and you don't have it, I would always err on the side of caution. So I wouldn't start them on early active if I didn't have an op report, unless you had specific orders or something like that. A couple things that will vary from our protocols that we always typically like to start early active, and we like to do that at that window of day 4 and day 5. So with that being said, you don't always get the patient on the days that you want to get them. Sometimes they come at 2 weeks, sometimes they come at 3 weeks for when you're starting range of motion. But I think this is where we as therapists can really do well with marketing ourselves by talking to the physicians and asking, hey, the next one you have, can you send them post-op day 4 or day 5 and give them the rationale why. And then another thing that's a little bit different about our protocol compared to the others, besides the St. John's and Amanda Higgins, is that we will sometimes just start with a wrist-free dorsal blocking, and we do that based on the work of Fiona Peck, who developed the Manchester splint. So it really varies, and with the wrist-free dorsal blocking, the other thing that guides our treatment is if we have a good relationship with that physician and we know that they're okay with using a wrist-free dorsal blocking. So if we don't have that relationship, we're certainly not going to do it because it is something that is newer and more people will question you more if you do it. So I would always say check with your surgeon first, make sure it's okay, make sure you have a good relationship, make sure you have the operative report. Okay, so let's get to the meat of things. We're going to be talking about the protocol and Hand Therapy Academy's protocol, and I'm going to go over it briefly, but also I want you to know that it's available on our website as well, so you can click on it and get everything listed out, which should make it a little bit easier for you. So within week 1, we're starting with a splint, of course. So like we said, we'd always start in a dorsal blocking splint, and with that, it's going to be wrist-free, and the MCPs are going to be in slight flexion. We don't want them all the way straight, but we also don't want a perfect measurement because we know that doesn't really matter. It's patient, there's so many variables that go into it, so just slight flexion. I would say around 40 to 50 degrees if you were going to measure though. We always start with passive flexion, active extension, so making sure that we're keeping the joints nice and supple. That way when the tendon is ready to do its work, it's a lot easier for the tendon to work. So start with passive flexion, active extension. And then the next thing we're going to do is we're going to initiate short arc range of motion, and that is done at day 4 or day 5 if at all possible, because remember, if it's after day 4, after day 5, there's less chance of bleeding, less chance of causing additional scar formation because of the bleeding. And then if you do it like if you did it at day 7, day 8, just remember that the collagen formation is being affected. So that window of time is important to note. And so with short arc flexion, I know different therapists will do where they put their hand at the distal palmar crease as a guide. So say my right hand had the flexor tendon injury, I'm going to use my hand as a guide, and then they'll say scratch the index finger. So the reason that they're saying scratch is to help facilitate FDP firing. But with us, sometimes that's a little complicated, or I found like, oh, I don't know, like the angle that the patient has their hand changes it significantly. So what we like to do at Hand Therapy Academy is make them dowels. So this is one dowel, and typically we start off with the dowel being fairly large because we want them to be moving around 30%. So 30% of their total active motion. So their dowel size will affect how much motion they have, their dowel and hand size. So I don't want you to get lost in this and measuring exactly what 30% is. That's not really important because the 5 or 10% one way or the other is not going to make a significant difference. So what I want you to have them do is you're going to have them make a dowel, and then week 1 you're going to say scratch it. And we want you to scratch it because a lot of times what happens, especially with zone 2 flexor tendons, is that the FDP gets stuck. So by scratching it, you're facilitating that movement. And then when you move to week 2, if you're starting to notice some signs of adhesions and stiffness, then you're going to make the dowel smaller. If they're moving just fine, you're going to keep the dowel the same. So this is similar to what Josh was talking about, is you're progressing it based on how they look clinically. And then in week 2, you're going to be doing some of the same things that you were doing in week 1, which include edema management. So you're talking to them about elevating their arm, maybe every hour doing some salutes like that, because we know that stimulates the lymphatic and helps with edema management. You're also going to be talking to them about moving their shoulder and elbow. So that's why I think this exercise is great as well, is because they get some shoulder and elbow range of motion. What people tend to do is they hold their arm in like this, so then their elbow gets tight. So you're going to be educating them on all of those variables. The other thing I want to make a note of is if you're managing edema with Coban wrap, that increases the work of flexion. So if you are going to do that, just know that they'll probably want to take it off when they do their range of motion, so they're not moving against that resistance. You're going to be educating them on wound care, changing their dressings daily. And with that, I know that this is variable amongst the surgeons that you may work for. Some like them to get it wet in the shower and let it dry out, but I also have some surgeons that like them to put a bag over it when they shower. So making sure that you know your surgeon's preference, and if you don't know, then always err on the side of caution. Another thing that you're going to do in week 1 and 2 is that you're going to do reverse joint blocking, and this is similar to what you learned in the earlier videos, is where you're going to put the hand in a protected position in the splint and then have them do extension. So you're going to have them extend the DIP, and then with the hand in that protected position, extend the PIP. And just know that you're always keeping the tendon on slack by keeping that flexed. So week 3, that's when you're getting into the scar remodeling. So you're going to want to start thinking about some of those scar management techniques, whether that be scar massage, education on moisturizers that are appropriate, maybe the use of silicone gel sheeting if the tissue is able to handle that. Week 4, so by week 4, this is when we say that they should be able to make a full fist. So we want them to be working on bringing it in. If they're close, I tell them still not to stretch it because they can rupture. So week 4, they're able to make a full fist. This is also when we start cone stacking. So where you're bringing the cone over and then asking them to fully extend. Now I don't want them trying to pull the cone off aggressively. I want them to kind of pop it up like that and bring it over. So educating them on no forceful grasping. And one other thing I wanted to mention is when you give patients the dowel, if you make them a dowel, so this is just out of built-up foam, but you can make it out of thermoplast. It's a great way to use up some of your scraps. But oftentimes I write a little note on there saying, don't squeeze. So when something's soft, patients think they need to squeeze it, and that's not what we want. We just want a touch. Okay, so then week 5, what's different? They're still in their splint, but then you can have them start doing rice. So just very gentle rice, and you may have them do some sifting in the rice. So they're doing that hook grasp as well as picking up. And in this week 2, in this week 4, you're also going to have them do tendon gliding exercises. So you may remember those. They're kind of the hallmark of hand therapy, but you're going to be doing hook, intrinsics, straight fist, full fist, just as a basic review. And then week 6, they're weaning out of the splint and they're beginning light resistance and putty. And I always use the note of caution when you start putty is you want to make sure that they're pretty well scarred in. So you want to be looking at their wounds, looking at their scar tissue. If they don't have full range of motion, that's almost optimal because you're having them move. You know that they have some scar formation beginning. So week 6, putty. At this time, you should be out of the splint, at least weaned out or in it at night. We don't want you using it during the day. Week 7 is just a continuation. There's no changes in the protocol at week 7. But then week 8, this is going to be a shocker to you all, return to full duty work. That's right, full duty work. I was so floored when I saw this, and when I was at the American Association of Hand Surgery conference, there was some publications done and supported by the AAHS saying that at week 8, patients do better if they return to work. There was no greater likelihood of rupture in the people who returned to work at week 8 compared to those who returned at a later date. So you can have your patients start returning. Of course, this is oftentimes guided by the physician, but know that that's what the clinical or the maintenance of certification says. So after week 8, you should be, progressing them. You may be fine-tuning things, working on things, but that's basically when you're starting to think about returning to all activities of daily living and those sorts of things. All right, one other thing that we like to cover in week 1 that we feel is very important in preventing ruptures is that's one-handed dressing techniques. And with one-handed dressing techniques, we like to go through the list of activities of daily living with each patient and problem solve with them of techniques that they can do to avoid using their other hand. Because remember, we want them to move it but not use it. So one thing that patients have to do every day is oral care, so brushing your teeth and flossing. So with that, I always recommend getting the cap that just kind of pops up, not one that you have to twist, because that's very hard. And then I like to have them lay the toothbrush down. So if it was their left hand that was injured, you're going to have them lay the toothbrush down and then squeeze the toothpaste on it and then just push the lid back down. So that's one way that you can do teeth brushing. The other thing that is important is the flossing, and then for that we always recommended one-handed flossers that you can buy. The other thing is for shaving, so for men and women, sometimes it's hard to do, especially if it's your non-dominant hand or your dominant hand that's injured. Shaving can cause cuts and things like that if you're not efficient with it. So we'll recommend using an electric razor for men and women. Showering, we like to use long-handled sponges. You can squeeze the soap out and use a long-handled sponge to get in those nooks and crannies, especially for people who use both hands and scrub their back. That can be a time that people need a little assistance. The other one is buttoning or dressing. So buttoning is under the dressing category. So one-handed dressing, we always want them to dress the affected limb first. So you'd have them slide the sleeve on and then reach around and get it with their other hand. Another part of that is buttoning their shirts. So if they can't button with one hand, you can always recommend a button hook. And we have these at our clinics to show people, but you can also make your own out of a paper clip and thermoplastic. So if it's a temporary thing, I may just make one for the patient, and they're really usually pretty appreciative of that. Toileting, sometimes people don't like to wipe with their other hand. Unfortunately, it's probably what they're going to have to do. So I will tell them, to make it a little bit easier, you can use wipes, disposable wipes, so it makes it a little less messy. The other thing where people struggle is in the kitchen with cooking and baking. So what you can do with cooking is you can buy adapted utensils. So you can buy the chopper so you don't have to chop a knife and hold the vegetable. There's also some cutting boards you can get that have nails, so you can educate patients on that. But also something very simple you can do for these patients is give them a piece of non-stick stuff. You can either use like shelf liners, or we have like a big roll of Dyson in our clinic where I may give it to the patient because they can put their plates down or their bowls down. That way it doesn't slide around when they're trying to cut or stir things. And then for heavy pots and pans, usually that's a bilateral hand task. You'll want to educate them on sliding those things on the counter. And other things that can help them with like putting their socks on or dressing the lower extremities using a dressing stick. So you can show them this stuff and then problem solve with them. If you want to show them how to put on their socks, then you can show them one-handed sock donning. But however, if they wear sandals all the time, that's not going to be important. So I just like to go through the typical tasks, the typical activities of daily living, and then problem solve with the patient. And once again, we have this all available on our website.